Rapid infusion of a non-dextrose IV solution, often warmed, such as lactated Ringer solution or normal saline, before initiation of the block, fills the vascular system to offset vasodilation. Typical preload IV quantities are 500 to 1,000 milliliters infused rapidly. If hypotension occurs in techniques such as rapid non-dextrose IV fluid bolus, maternal repositioning, and oxygen administration are ineffective, IV phenylephrine in increments of 50 to 100 micrograms or ephedrine in increments of 5 to 10 milligrams to promote vasoconstriction to raise the blood pressure. Yeah, there's so many typos and grammatical errors in this book that it's kind of depressing. I just wanted to point that out. Bladder distension. A woman's bladder fills quickly because of the large quantity of IV solution, but her sensation to void is reduced. Distension may cause pain that remains after initiation of the block and may interfere with fetal descent in labor. Prolonged second stage. Delayed pushing is often intentional for second stage labor, and the urge to push may be less intense for the woman who has an epidural block, particularly if she has an intense motor block. The pelvic muscles may be relaxed, which can interfere with the mechanism of internal rotation. Factors increase the chance for vacuum extractor-assisted births or forceps-assisted births. Catheter migration. After accurate placement, the epidural catheter may move. It may then have symptoms of intravascular injection, an intense block, or one that is too high, absence of anesthesia, or a unilateral block. The anesthesia professional should be notified of any question about catheter placement. Cesarean births. Early research on whether cesarean births were more likely for women who had epidural blocks did show risk, but the epidural block was much more intense than current epidurals. More recent research has not shown epidurals to increase the risk for cesarean birth, although the length of the second stage is likely to be longer than for the woman who did not have an epidural. Maternal fever. For reasons that are not completely clear, fever after epidural analgesia during labor is common. The fever associated with epidural analgesia is usually not caused by infection, but may result from the reduced hyperventilation and decreased heat dissipation. For example, reduced sweating, which occur when the woman's pain is relieved. Another typo. Also, women who are having prolonged labors may be more likely to have epidural block analgesia. Fever is also a marker for infection. To avoid needless administration of antibiotics and sepsis evaluations in the newborn, other indicators for infection, for example, fetal tachycardia or amniotic fluid with a cloudy or yellow color and a foul or strong odor, should be sought as well. The nurse should remember that maternal fever elevates fetal temperature, and tachycardia and oxygen demand for both. Medical and nursing personnel should try to lower the mother's temperature to a normal level and identify and treat a suspected infection. Signals to the hypothalamus that may result in maternal fever after epidural block include the following. 1. Decreased hyperventilation, sweating, and activity after onset of pain relief reduce maternal heat production and signal the hypothalamus to raise the woman's temperature. 2. Vasodilation redistributes heat from the core to the periphery of the body, where it is lost to the environment. The lower core temperature then signals the hypothalamus to increase heat production. 3. Shivering often occurs when sympathetic blockade accompanied by a dissociation between warm and cold sensations. In effect, the body believes that the temperature is lower than the true temperature and raises the thermostat to produce heat by shivering, thus increasing the core temperature. Adverse effects of epidural opioids. Adverse effects associated with epidural opioids may include nausea and vomiting, pruritus, and delayed maternal respiratory depression. Nausea and vomiting. Nausea and vomiting occur during labor. Sometimes it is related to epidural opioid administration. It may be associated with hypotension due to patient position or neuraxial analgesia. Blood pressure should be immediately assessed and the woman repositioned. Adjunctive drugs such as metoclopramide Reglan, ondansetron Zofran, or droperidol may be used to reduce nausea and vomiting that can occur with epidural opioids. Pruritus. Itching of the face and neck is an annoying side effect that may occur with epidural opioids. Although she may not specifically complain of itching, a woman may rub or scratch her face and neck. Diphenhydramine, Benadryl, Naloxone, Narcan, Nalbuphine, Nubane, or Naltrexone, Trexan may relieve pruritus. Shivering. Shivering is common in labor and sometimes is associated with epidural anesthesia. Cause is unknown. Delayed respiratory depression. The possibility of late respiratory depression in the woman exists for up to 12 hours after the administration of an epidural opioid, depending on the duration of action of the drug used. Nursing care. Nurses with proper education who have demonstrated current competence should be able to participate in management of pain relief during labor. The nurse should record baseline maternal vital signs and FHR patterns for comparison with prenatal levels and those after the block. IV access is ensured and the prescribed preload of fluid is given. The nurse supports the woman in the correct position and tells the anesthesia provider when the woman is having a contraction. The woman may feel a brief electric shock sensation as the catheter is passed. The nurse should assist her in remaining still while the block is completed. After the medication is injected, the nurse observes for signs of subarachnoid puncture or intravascular injection. Evidence-based practice guidelines for AHWAN and the American College of Obstetricians and Gynecologists suggest assessing the maternal blood pressure and FHR every 5 minutes during the first 15 minutes after initiation of the epidural or any additional bolus doses of epidural medication. Repeat assessment of BP and FHR at 30 minutes and at 1 hour after the procedure. Individual facilities may use these guidelines or develop their own guidelines. As in any labor, maternal and fetal assessments are done more frequently if needed in situations such as maternal bleeding or a non-reassuring FHR pattern. The woman's bladder should be assessed frequently because of the large IV fluid load and her reduced sensation to void. Indwelling catheterization is common, but intermittent catheterization, if a woman is unable to void, is recommended by AHWAN. Based on results from varied researchers that support a woman's ability to void or need few, if any, intermittent catheterizations, the goal of labor caregivers should be to support normal urination rather than catheterizing all women with epidural analgesia. The nurse should observe for signs associated with catheter migration from the epidural space and for adverse effects from epidural opioids such as nausea and vomiting and pruritus. Reassurance about the harmless and temporary nature of pruritus is often sufficient. Intrathecal opioid analgesics. Intrathecal injection of an opioid analgesic provides another option for pain management without sedation. The drug is injected into the subarachnoid space, where it binds to opiate receptors, allowing much smaller doses than would be adequate if given systemically. The woman can feel her contractions, but not the pain they would otherwise cause. Advantages of intrathecal analgesics include the following: rapid onset of pain relief without sedation, no motor block enabling the woman to ambulate during labor, no sympathetic block with its hypotensive effects. Disadvantages may include the following: limited duration of action, possibly requiring another procedure for continued pain relief, inadequate pain relief for late labor and the birth, requiring added measures to manage pain at these times. Combining intrathecal opioids with epidural blocks in a combined spinal epidural (CSE) provides rapid pain control at time an epidural catheter is placed. Epidural drugs are then given to provide a long-acting block for labor. Technique. The subarachnoid space is entered with a spinal needle, as in the subarachnoid block, SAB. A preservative-free opioid analgesic is then injected. The drug chosen depends on the expected duration of labor at the time it is given. Drugs that may be used by this route include fentanyl, sufentanil, and morphine. One technique for performing the CSE is to insert the epidural needle into the epidural space. The much thinner spinal needle is then inserted through the larger epidural needle to reach the subarachnoid space for injection of the intrathecal opioid. The smaller needle is then withdrawn, and an epidural catheter placed for injection of epidural medication. Adverse effects of intrathecal opioids. As with epidural opioids, nausea, vomiting, and pruritus may occur. Delayed maternal respiratory depression may occur, depending on the drug used. Nursing care. Vital signs and FHR are taken at the usual intervals for the woman's stage of labor. Side effects such as nausea and vomiting or pruritus are reported and managed similarly to those occurring with the epidural block. Reduced effectiveness suggests that the drug's duration of action is ending or that a woman is in late labor. Other pain management methods may be needed for the remainder of labor and for birth. Care for the woman undergoing a CSE block is the same as that for one receiving a non-combined block. Subarachnoid spinal block. An SAB is a simpler procedure than the epidural block and may be performed when a quick cesarean birth is necessary and an epidural catheter is not in place. It is similar to local infiltration and Pudendal Block. SAB is performed just before birth, providing no pain relief during most of labor. The physician or nurse anesthetist ingests local anesthetic into the subarachnoid space in a single dose. The woman loses both sensory and motor function below the level of the SAB, with relief of pain from contractions. Technique. 25 to 27 gauge spinal needle is placed in the subarachnoid space. Appearance of CSF at the needle hub ensures correct placement, and the local anesthetic is injected, figure 13.11. The level of anesthesia for both epidural blocks and SABs is determined by the volume, concentration, and density of the drug, figure 13.12. Contraindications and precautions. Contraindications and precautions are similar to those for epidural block. The woman's refusal, coagulation defects, uncorrected hypovolemia, infection in the area of insertion, systemic infection, and allergy. Adverse effects. 3 adverse effects of an SAB are maternal hypotension, bladder distension, and postural puncture headache. Hypotension is more likely with the SAB than with the epidural block and is treated in the same manner, often with a larger volume of preload IV fluid. Bladder distension is managed with ongoing assessments, support of the woman's ability to avoid an intermittent catheterization if necessary. Postural puncture headache. Postural puncture headache may occur after SAB in some women because of CSF leakage at the site of dural puncture. A spinal headache is postural. It is worse when a woman is upright and may disappear when she is lying flat. Headache is less likely if a small gauge needle is used. Bed rest with oral or IV hydration helps relieve the postural puncture headache. Caffeine is another oral therapy. A blood patch may provide definitive relief. The blood patch involves injection of a small amount of the woman's blood obtained with sterile technique into the epidural space. The blood causes a tamponade effect and may form a gelatinous seal over the hole in the dura, stopping spinal fluid leakage. Systemic drugs for labor. Systemic drugs have effects on multiple systems because they are distributed throughout the body. These intrapartum drugs include opioid analgesics and adjunctive drugs. Although general anesthesia is also systemic, it is discussed separately because it is used only at birth and causes loss of consciousness. Nitrous oxide. Nitrous oxide, laughing gas, is used for labor pain management in several Western countries and was used briefly in the United States in the early to mid 1900s. Its use is returning to this country. Nausea, vomiting, and dizziness are some of the possible side effects to consider. For labor pain, the gas is delivered as 50% nitrous oxide and 50% oxygen. Nitrous oxide in labor is self-administered. The woman controls when she takes breaths of the 50-50 combination. Parenteral analgesia. Opioid analgesics are the most common parenteral medications given to reduce perception of pain without loss of consciousness. Analgesics that may be used for labor are mepridine, Demerol, fentanyl, Sublamaze, butorphanol, Sterile, and nalbuphine, Nuben. See Table 13.1. Although the drug may be prescribed for labor analgesia, mepridine often produces a dysphoric rather than an analgesic effect in the woman. She may be restless or irritable and have twitching, jerking, shaking, tremors, or even delirium. More concern is that mepridine produces a long-lasting active metabolite, normepridine. Normepridine accumulates in fetal tissue and can cause neurobehavioral changes for 2 to 3 days of life. For this reason, mepridine use in labor is becoming controversial. Mepridine and fentanyl are pure opioid agonists, or substances that cause a physiologic effect, but butorphanol and nalbuphine have mixed opioid agonist and antagonist substance that blocks another substance or body secretion effect. A woman who is dependent on opiates, e.g. heroin, should avoid agonist-antagonist drugs because they may cause withdrawal effects in her and the newborn. They should not be given if the woman has already received a pure opioid because some analgesic effect of the first drug will be reversed. Agonist-antagonist drugs have a ceiling effect on the amount of analgesia they provide and are unsuitable for the increasing pain of the entire labor for many women. The primary side effect of opioids is respiratory depression, which is more likely to affect the newborn. Timing of administration is important to reduce neonatal respiratory depression. An infant who is born at the peak of the drug's action is more likely to have respiratory depression than if born earlier or later. Normepridine can cause delayed respiratory depression in the newborn because of its lengthy duration of action in the newborn. Opioid analgesics are given in small frequent doses by the IV route during labor to provide a rapid onset of analgesia and a predictable duration of action. The woman will benefit from rapid pain control with less likelihood of neonatal respiratory depression. Starting the injection at the beginning of the contraction when blood flow to the placenta is normally reduced limits transfer to the fetus. When placental blood flow resumes, more of the drug is in maternal tissues. The drugs may be delivered by patient-controlled analgesia PCA pump. Opioid antagonists. Naloxone, Narcan, reverses opioid-induced respiratory depression. Naloxone does not reverse respiratory depression from other causes, such as barbiturates, anesthetics, non-opioid drugs, or pathologic conditions. Naloxone has a shorter duration of action than most of the opioids it reverses, and respiratory depression may recur. In an opiate-dependent woman or newborn, naloxone can induce withdrawal symptoms. Airway management, i.e. bag and mask ventilation, takes precedence over use of naloxone for the newborn, and the drug is not routinely given to the baby for respiratory depression. Adjunctive drugs. Adjunctive drugs during the intrapartum period include those with antiemetic and tranquilizing effects and sedatives. These drugs are given to reduce nausea and anxiety and to promote rest. Metoclopramide can increase gastric motility and reduce nausea and vomiting. It also can cause drowsiness. Sedatives. Sedatives such as barbiturates are not routinely given because they have prolonged depressant effects on the neonate. However, A small dose of short-acting barbiturate may be given to promote rest if a woman is fatigued from false labor or a prolonged latent phase. Vaginal birth anesthesia. Local infiltration anesthesia. Infiltration of the perineum with a local anesthetic is done by the physician or nurse midwife before an episiotomy or perineal repair, figure 13.14. Local infiltration does not alter pain from uterine contractions or distension of the vagina. The local agent provides anesthesia in the immediate area of the episiotomy or laceration. A short delay occurs between anesthetic injection and onset of numbness, and the drug burns before its anesthetic action begins. Local infiltration rarely has adverse effects on either mother or infant. Pudendal Block. A pudendal block anesthetizes the lower vagina and part of the perineum. It is often used to provide anesthesia for an episiotomy and vaginal birth, especially one that requires using low forceps. A pudendal block does not block pain from uterine contractions, and the mother feels pressure. The pudendal block is a highly localized type of regional block, like a dental anesthetic that provides numbness for dental procedures. The physician or nurse midwife injects the pudendal nerves near each ischial spine with a local anesthetic, figure 13.15. The perineum is infiltrated with local anesthetic because the pudendal block does not fully anesthetize this area. As in local infiltration, a brief delay occurs between injection and onset of numbness. Possible maternal complications include a toxic reaction to the anesthetic, rectal puncture, hematoma, and sciatic nerve block. If maternal toxicity is avoided, the fetus usually is not affected. General anesthesia. General anesthesia is systemic pain control that involves loss of consciousness. It is rarely used for vaginal births, but it still has a place in cesarean birth. Some women either refuse or are not good candidates for epidural block or SAB for cesarean birth. Occasionally, a planned epidural block or SAB proves to be inadequate for surgical anesthesia. General anesthesia may be needed unexpectedly and quickly for emergency procedures at any stage of pregnancy, such as to repair injury that results from an accident or domestic violence, to perform an appendectomy. Technique. Before induction of anesthesia, a woman breathes oxygen for 3 to 5 minutes, or at least 4 deep breaths to increase her oxygen stores and those of her fetus. For the short period of apnea during rapid anesthesia induction, the woman has a wedge under one side, usually her right, or the operating table is tilted, to reduce aortic cable compression and increase placental blood flow. Adverse effects. Major adverse effects are possible with the use of general anesthesia. Maternal aspiration of gastric contents. Regurgitation with aspiration of acidic gastric contents is a potentially fatal complication of general anesthesia. Aspiration of food particles may result in airway obstruction. Aspiration of acidic secretion results in a chemical injury to the airways. Aspiration pneumonitis. Infection often occurs after the initial lung injury. Respiratory depression. Respiratory depression may occur in either the mother or the infant, but is more likely in the baby. This is more likely to occur if the interval between induction of anesthesia and cord clamping is long. Uterine relaxation. Some inhalational anesthetics may cause uterine relaxation. This characteristic is desirable for treating some complications. For example, replacing an inverted uterus. However, postpartum hemorrhage may occur if the uterus relaxes after birth. Methods to minimize adverse effects. Measures to reduce the risk for maternal aspiration or to limit lung injury if aspiration occurs include the following: restricting intake to clear fluids or maintaining nothing by mouth NPO status if surgery is expected, such as with a scheduled cesarean birth. Administering drugs to raise the gastric pH and make secretions less acidic. For example, sodium citrate and citric acid, Citra, ranitidine, Zantac, cimetidine, Tagamet, or famotidine, Pepsid. Administering drugs to reduce secretions, for example, glycopyrrolate, Robinul. Administering drugs to speed gastric emptying, for example, metoclopramide, Reglan. Using cricoid pressure, Sedlick's maneuver, to block the esophagus by pressing the rigid trachea against it. Neonatal respiratory depression may be minimized by doing the following: reducing the time from induction of anesthesia to clamping of the umbilical cord, keeping use of sedating drugs and anesthetics to a minimum until the cord is clamped. To reduce the time from induction of anesthesia to cord clamping, the woman is prepared and draped, and the physicians are ready before anesthesia is induced. The anesthesia is kept light until the infant is born, and the woman may move slightly on the table, although she usually has no memory of the experience. The anesthesia level is deepened as soon as the cord is clamped. Application of the nursing process, pain management. Nursing care related to pain management should be combined with support for normal labor and any complications that arise. Care of the fetus remains important. Two problems that affect many women are pain and care related to epidural analgesia. Pain assessment. Pain assessment begins at admission and continues throughout labor and postpartum, Table 15.1. Pain-related assessments include the following: preferences for pain management, previous surgeries, types of anesthesia, and any anesthesia-associated problems, maternal vital signs, FHR and EFM patterns. Allergies, focused especially on allergy to opioid analgesics, dental anesthetics, and iodine, used in some skin preparation solutions. Oral intake, time and type of last intake. Evidence of pain, verbal statement, requests for pain relief measures, crying, moaning, and nonverbal evidence such as tense, guarded posture or facial expression. Labor status. In addition to these routine assessments, ask the woman if she needs help with pain management. A stoic woman may give little evidence of pain, yet may say she wants pain control if asked. When assessing pain, clarify the words a woman uses. When asked if she has pain, the woman may deny it. Yet changing the word used to discomfort, cramping, aching, pressure, or other words that may describe labor pain may elicit a different response. Do not assume that everyone uses the same words to describe pain. Pain is an individual experience, and so is the expression of pain. Asking a woman to rate her pain on a scale of 0 to 10, or your facility's standard scale, helps clarify her pain's intensity. A 0 represents no pain, whereas 10 is the worst possible pain. Ask the woman to rate her pain on this scale before and after pain relief measures to evaluate their effectiveness. Multilingual and picture scales are available for those who do not speak the dominant language. A surprising number of women have difficulty using a pain scale because they have little experience with pain. They may underrate current pain, expecting an increase in the amount of pain, and therefore pain number, later in labor. Or they may say that they have no idea what the worst pain imaginable is, therefore cannot guess how a pain rating of 10 feels. Scale or description by the woman does, however, provide one measure of how pain feels before and after relief measures. Language gives a clue to comfort level. Moaning, crying, thrashing, and an inability to use non-pharmacologic techniques are likely indicators that a woman needs help with pain control, including pharmacologic pain relief. However, more subtle cues, such as remaining tense between contractions, also suggest difficulty coping with pain. Evaluate the woman's labor status to help her choose the most appropriate method of pain control. Inform her if she has reached a decision point in labor to use or not use a specific pharmacologic method. No standard time or amount of cervical dilation serves as a guideline for this critical point. This is estimated based on projected time of birth, amount of time needed to establish a specific method, and the pharmacology of the drug or drugs. Avoid making assumptions about a woman's pain based on her rate of labor progress, cervical dilation, or apparent intensity of contractions. Do not assume that a woman whose cervix is 2 centimeters dilated has little pain and that a woman whose cervix is dilated 8 centimeters has intense pain. An obese woman's contractions may be strong, but they may seem mild if they are assessed by palpation or an external monitor because of her thick abdominal fat pad. Labor progress or contraction intensity cannot be equated with a woman's pain perception or tolerance. A woman's need for pain relief should not be based only on her outward expression. A quiet woman may need medication but may be reluctant to ask, whereas an expressive woman may be satisfied with only non-pharmacologic measures. Because women who do not speak the prevailing language may not know what is available, seek an interpreter not related to the laboring woman to communicate most effectively. Observe for and report pain that is not typical of normal labor. Although labor pain is often intense, it should come and go with each contraction. The uterus should not be tender or board-like between contractions and should not cause constant intense pain. Identification of patient problems. Analysis of the data collected enables the nurse to identify actual and potential patient problems and develop an individualized plan of care. Pain is expected in normal childbirth, and most laboring women have nursing needs that relate to its management. Pain from the effects of uterine contractions and fetal descent may be an appropriate problem. Planning expected outcomes. Because pain is a subjective experience and expected in labor, two expected outcomes are realistic. The woman will do the following. 1. Describe pain relief measures, both non-pharmacologic and pharmacologic, as satisfactory during labor. 2. Effectively use breathing and relaxation techniques learned in childbirth class or from the nurse during labor. Interventions. Nursing care related to intrapartum pain management focuses on reducing factors that hinder the woman's pain control and enhancing those that benefit it. Although epidurals are very common in North American hospitals, do not make the assumption that every woman will want one for birth. Carrying contact with the nurse enhances pain management and the overall experience of giving birth. Promoting relaxation. Simple attention to details promotes relaxation. Make the environment more comfortable. If noise is a problem, suggest music or television to mask it. A warm blanket, a cool cloth, or a warm pack provides tangible comfort and conveys the nurse's caring attitude. And underpads as needed to keep the woman reasonably clean and dry. Offer the woman a warm shower or bath, especially if she is tense and if no contraindications exist. In general, walking is good during early labor, and water therapy is better during active labor. The mild nipple stimulation that occurs in a whirlpool or shower may intensify contractions in a woman whose labor has slowed, causing her posterior pituitary gland to secrete oxytocin. Reduce intrusions as much as possible. For example, wait until a contraction is over before asking questions or performing a procedure. Longer assessment and procedures may span several contractions, but try to stop during each contraction if possible. Reducing outside sources of discomfort. Anesthetize the IV site with lidocaine before inserting the line if the woman is not allergic and if policy permits. Normal saline infiltration of the site has a similar effect. Remind her to change position regularly to reduce tension and discomfort from constant pressure. Support her with pillows. Observe the woman's bladder for distension hourly and encourage her to void every 2 hours or more often if she has received a large quantity of IV fluids. Most intrapartum order sets include an order for catheterization if the woman cannot void and her bladder is full. Reducing anxiety and fear. Accurate information reduces the negative psychological impact of the unknown. Tell the woman about her labor and its progress. You cannot predict when she will give birth, but tell her if labor progress is or is not on course. Sometimes she needs only the reassurance from an experienced nurse that her intense contractions are indeed normal. The woman may be willing to endure more discomfort than she otherwise would if she is making progress. Be honest if problems do occur. A woman usually knows if a problem exists and is more anxious if she does not know what it is. Explain all measures taken to correct the problem and inform her of the results. Helping the woman use Non-pharmacologic techniques. If the non-pharmacologic method is safe for the woman and fetus, and if it is effective, do not interfere with its use. Try not to distract the woman from whatever technique she is using. Massage. Fetal monitor belts hinder abdominal effleurage. Encourage the woman to do effleurage on uncovered areas of her abdomen or to stroke her thighs. Consider using intermittent auscultation or intermittent EFM, see Chapter 14. Use powder to avoid friction and seek feedback from the woman about the best location and amount of pressure to use for sacral pressure or other massage. Because this information may change during labor or massage may become uncomfortable rather than helpful, seek the woman's feedback regularly. Mental stimulation. Use a low, soothing voice when helping a woman use imagery. Speaking close to her ear is often helpful when trying to create a tranquil, imaginary scene or to calm her. Use of a low, soothing voice during an emergency has a calming effect as well. Music can enhance mental stimulation techniques. Breathing. Women often modify the techniques they learn in class or invent some of their own during labor. Encourage the woman to change techniques when she feels it is necessary, but to save the complex ones for later labor. If she has trouble maintaining her concentration, the nurse or her support person may try to make eye contact, if culturally appropriate, and breathe the pattern with her. Hyperventilation, dizziness, tingling, and numbness of the fingers and lips, carpopedal spasm, are likely if a woman breathes fast and deep. If she hyperventilates, she should breathe into her cupped hands, a paper bag, or washcloth placed over her nose and mouth. Talk to her gently to slow her breathing. Teach breathing techniques to the unprepared woman and her coach when she is admitted. Review them when she seems to need a different method. If she makes up a breathing technique that works, leave it alone. When teaching pain management techniques to the unprepared woman who is in advanced labor, follow these guidelines. Teach one method at a time. Demonstrate the method between contractions. Use breathing techniques with the woman while maintaining eye contact. Give her control over her labor, e.g., who is present or what technique she will use. Speak in a soft, calm tone of voice. Incorporating pharmacologic methods. All pharmacologic methods require collaboration with medical personnel for orders. Tell the woman soon after admission what medication is available if she needs it. This is intended not to undermine her self-confidence, but to allow her to make an informed choice about medication when necessary. Analgesia is most effective if it is given before pain is severe. Tell the woman that her preferences about pain relief methods will be honored if possible, but predicting the course of her labor is impossible. Her preferred method of pain management may be inappropriate if labor has unexpected developments. No pharmacologic method will be used without her understanding and consent. If a woman finds non-pharmacologic methods inadequate, help her try other ones or offer her available medication. When contacting the birth attendant for medication orders, report the fetal and maternal status and vital signs, labor status, request for medication. If she has a continuous epidural block, contact the person who inserted it if problems occur. Observe special nursing considerations associated with the method used, Table 13.2. Evaluation. Labor is not expected to be painless, even with the most effective pharmacologic methods. The first goal or expected outcome is achieved if the woman is satisfied with her ability to manage her pain. Many women have occasional difficulty using breathing or other techniques, even if they have practiced faithfully. The nurse may ask the following questions. How did the woman's pain scale rating change before and after the pain relief method? Were non-pharmacologic or pharmacologic methods used? Is she satisfied with her level of pain relief? Epidural Analgesia. Many women choose epidural analgesia for pain relief during labor because of its effectiveness without sedation. Epidural block analgesia requires several specific nursing assessments and interventions. Assessment. The admission assessment focuses on possible allergies to local anesthetics or opioid drugs that might be used in the block. Determine baseline maternal vital signs and the FHR and pattern. Assess for any skin infection of the back where the epidural will be inserted. Identification of patient problems. Primary risks associated with epidural analgesia are maternal hypotension and injury. These result in collaborative problems. Potential complication, maternal hypotension with secondary fetal hypoxia. Potential complication, patient injury resulting from reduced sensation and movement secondary to epidural effects. Planning, expected outcomes. Appropriate goals or expected outcomes are: 1. The woman has achieved the outcome if her blood pressure and the FHR pattern do not change significantly after the epidural, and 2. The woman has achieved the outcome if she does not have a treatment-related injury while her sensation and mobility are reduced. Interventions. Maternal hypotension. Maternal hypotension reduces blood supply to the placenta, decreasing fetal oxygen and nutrient supply and waste removal. Birth facilities will have policies that provide specific guidelines for care when women receive epidural block. Infuse the prescribed IV solution, typically 500 to 1000 ml as ordered, before the block's initiation. If the woman has not received the full amount when the block has begun, notify the anesthesia professional. The epidural may be placed with the woman in the sitting or side-lying position based on the decision of the anesthesia provider. She is in a sitting position, hugging a pillow or a small birth ball helps her hold a correct position. Tell the anesthesia clinician when the woman is having a contraction. Warn the woman that she may feel a brief electric shock sensation as the catheter is passed. After the epidural is initiated, maintaining her position so that aortic cable compression is avoided, for example, by placing a pillow under one hip. Measure the woman's blood pressure and pulse rate, often an automatic cuff is used, every 2 to 3 minutes or per the facility's protocol for 15 to 20 minutes after the initial injection of medication, comparing the values with her baseline blood pressure and pulse rate. Maintain continuous EFM. A significant blood pressure decrease, say 20% fall from baseline, or a drop to 100 milligrams mercury or lower systolic. Hypotension of any degree accompanied by FHR decelerations or loss of variability is significant. If hypotension occurs, increase the rate of her IV fluid infusion, keeping her position to avoid aortocable compression. Phenylephrine 50 to 100 micrograms, or ephedrine, usually 5 to 10 milligrams, is ordered if hypotension is significant and a fluid increase does not quickly improve it. When the blood pressure is stable, assess it every 15 minutes. If hypotension occurs, report it to the professional who oversees the anesthetic for definitive treatment. Pulse oximetry identifies a decrease in maternal oxygenation status to below 95%. Continue observing the FHR. Signs of reduced placental perfusion may be evident before the woman shows signs of hypotension. These include fetal tachycardia, more than 160 beats per minute, BPM, or bradycardia, less than 110 BPM. Prolonged decelerations and late decelerations, see Chapter 14. Monitor the mother's temperature to identify elevations that also may contribute to fetal tachycardia. Avoidance of injury. Epidural block reduces lower extremity sensation and movement to varying degrees. Some women have such a light motor block that their epidural is called a walking epidural. However, to prevent falls, these women should not walk alone. They should remain in bed or sit in a nearby chair after their epidural has begun because of reduced sensation. Assess the degree of motor block and sensation hourly. If a distinct increase or change is noted, refer to the anesthesia clinician because this may indicate catheter migration or another complication. A woman who has reduced mobility and sensation should be moved so that she maintains an anatomic position. Avoid prolonged pressure on one area. Remember that changing position often improves labor progress. even if the woman does not need to change positions for comfort. If surgery is needed, pad bony prominences to reduce pressure on those areas. Before any ambulation, such as for urination after birth, test the woman's ability to raise and move her legs. Have her push her legs against your hands to determine her leg strength. When she ambulates, accompany her and monitor her ability to move and her strength the entire time the epidural is in effect. The woman should sit before standing to evaluate for postural orthostatic hypotension, which may occur in any postpartum woman regardless of her pain management methods during labor. Evaluation. The nurse evaluates the reduction of potential for injury by comparing the woman's baseline blood pressure and FHR to those after the block is begun to identify any significant changes. The goal or expected outcome related to injury is achieved if the woman does not have an injury related to her altered sensation and mobility while the epidural block is exerting its effects. Application of the nursing process, respiratory compromise. Assessment. General anesthesia may be needed anytime during birth, most often for cesarean birth. Document the type, solids or liquids, and time of the woman's last oral intake. Question her closely if she reports an unusually long interval since her last intake. Anesthesia providers can anticipate and prevent problems better if they know the actual oral intake. Although most assume that every woman has food in her stomach, and induce general anesthesia accordingly. Identification of patient problems. Analysis of the data collected enables a nurse to identify actual and potential patient problems and develop an individualized plan of care. The woman is at risk for respiratory compromise as a result of aspiration. Planning expected outcomes. The expected outcome is that the woman will not experience respiratory compromise from aspiration of gastric contents during the perioperative period. Interventions. Nursing interventions relate to identifying factors that increase a woman's risk for aspiration, as well as collaborative and nursing measures to reduce the risk for aspiration or lung injury. Identifying risk factors. Report oral intake both before and after admission to the anesthesia provider. Oral intake during labor may be restricted to medications, clear liquids such as water and ice, clear fruit juices, carbonated drinks, clear tea and coffee, sports drinks, popsicles, or hard, sugar-free candies. Vomiting is a common occurrence during normal labor, regardless of the mother's oral intake. If vomiting occurs, chart the time, quantity, and character, amount, color, presence of undigested food. Reducing risk for aspiration or lung injury. Nurses collaborate with medical personnel to reduce a woman's risk for pulmonary complications. Perioperative care. Restrict oral intake as ordered, if surgery is expected. Give ordered medications such as sodium citrate and citric acid by Citra. Depending on when the medications are needed, either the nurse or the anesthesia provider may administer parenteral drugs such as glyporolate, Robinul. An experienced nurse or trained anesthesia assistant provides cricoid pressure, Salix maneuver, until the woman is intubated and the cuff of the endotracheal tube is inflated. Successful intubation with the cuffed endotracheal tube blocks passage of any gastric contents into the trachea. However, the value of cricoid pressure has not been thoroughly researched. Post-operative care. Birth facility protocols guide post-operative care, including pre-extubation and post-extubation care for the woman who has had general anesthesia. The woman is extubated when her protective laryngeal reflexes have returned, often before transfer from the operating table. Suction equipment and an ambu bag with appropriate size mask should be immediately available not only in the operating room and post-anesthesia care unit, but also in standard patient care rooms on the nursing unit. Administer oxygen by mask or face tent for 2 to 5 minutes until the woman is awake and alert, because the agents used for general anesthesia are respiratory depressants. Monitor oxygen saturation with a pulse oximeter. If oxygen saturation falls below 95%, have her take several deep breaths. Deep breathing also helps her eliminate inhalational anesthetics and reduces stasis of pulmonary secretions. Assess the woman's pulse rate, respiration, and blood pressure every 15 minutes for 1 hour or until stable. Then continue per policy. In addition to using pulse oximetry, observe her color for pallor or cyanosis, which respectively suggest shock or hypoventilation. Evaluation. Interventions for this patient problem are preventative and short-term because it is temporary, high-risk situation. The goal is met if the woman does not aspirate gastric contents during the perioperative period.